Hi guys, a very good evening to everybody. I think we'll get started in about few seconds from now. Hi, great. I'm perfectly fine, confused medical, but finally I think you guys would be relieved after going through everything. I can understand the amount of pressure that you guys went through, especially with that rainy morning and wading through that knee-deep water. I think it was really a tough ride, but kudos to you that you guys are persisting. So cool. Uh, Adenosine dose, doctor, I would like to know from you regarding the adenosine dose question, because I think it was a pediatrics question with respect to the dose administration. Because in adults, I think we are giving 6 and 12 milligram, but in pediatric dose, it would be like 0.1 and 0.2 that would be given. So very good evening, SK. PR interval, doctor, is 0.21 was elevated. So I think it is a first degree heart block. So it would be, yeah, it is a 2. Yeah, Meet. You're right. It was a 2-year-old kid. That is why the dose was, I mean, that might have appeared inappropriate to you because we traditionally talk about the adult dosages. So cool, guys. Let's just solve the options and you can assist me with if there are any discrepancies. Uh, uh, okay, Akash, I would like to focus at these options at the moment. You please drop me a mail at marvamedicine@gmail.com. I agree, doc, but then standard information is about 0. Because if PR interval is prolonged, no, the single answer would be only a first degree heart block. Otherwise, you need a drop, no? I mean, in Mobitz 1 and Mobitz 2, for second degree, you need a block. For third degree, you need a variable PP and a RR interval. So I'll come to that question. Let's start. Starting with the first one, we are having a patient who's having features of right heart failure. Yeah, one of the question is normal, doctor, but then normal would be up to 0.2. I'm going to come to that question. Give me a couple of seconds. We are having a chap with right heart failure. The pulse, I think they love this irregular pulse. So maybe like the atria were dilated, auscultation of a loud diastolic sound. So I think here, loud diastolic sound, I initially thought was maybe he's trying to talk about a murmur. But I think you can clarify here, was a murmur word mentioned there or not? Because that's a very pertinent point, because that changes the entire dimension. But the moment he's gonna say rapid Y descent on a cardiac examination, then you know that rapid Y descent or steep Y descent both mean the same, and that goes in favor of constrictive pericarditis, because in constrictive pericarditis atria will be dilated. So that can explain the irregular pulse. And then this loud pericardial sound that he's trying to say, maybe he did not want to use the word pericardial shudder, but this is what I think that the examiner was trying to say. Pericardial shudder is a diastolic finding. It's the blood hitting against the wall and then bouncing off. And that is why the alternative term for this is like pericardial knock or pericardial shudder, pericardial. I mean, these are terms like shock, knock, and shudder. So that would make it options like constrictive pericarditis. Dilated cardiomyopathy would not change the output in this case, because dilated cardiomyopathy would not have this presence of, I mean, dilated cardiomyopathy will have a pan-systolic murmur. So great, Pushpender, thanks for that input. I'll just try to see if we can check that out. Okay, DCM says Dr. Muhammad also. Hi, Muhammad Riaz. So considering dilated cardiomyopathy, I mean, why am I ruling it out is because that would be a pan-systolic murmur due to dilatation of the tricuspid annulus. And Doc, we'll just do all the questions. So just be patient, and I think it's a mix and match of all of them. I'll say the salient features in next 30 seconds before I go on to the next one. My rationale for irregular pulse is that we have dilated atria in this condition. The reason for the dilated atria would be constrictive pericarditis calcification. So the atria will have to work against the resistance, and that's why the structural damage can occur. Loud diastolic sound is pericardial shudder, and rapid wide descent helps us in working out the answer. So Jai Shri Ram, guys. Answer is A to this one. And then there was a question on an athlete who went testing for a competition and was found to have hypertrophic cardiomyopathy. I just want to know that cardiomyopathy word was given in the question or not. And second, he has asked regarding which of the following will increase the murmur. So in the hemodynamics, our objective is mainly to identify that, murmurs of HOCM and mitral valve prolapse always behave opposite of what the standard information is, because the venous return to the heart will decrease with Valsalva, standing, and amyl nitrate, because less blood will come in the heart and less will be going out. But hypertrophic cardiomyopathy, you will always notice the murmur will become always louder. And I think that is what he's trying to ask. And for mitral valve prolapse, it will always be relatively longer. I mean, that's the basic standard statement that I would like you to remember. Okay, chronic constrictive pericarditis. Okay, doctor, it would not change much the constrictive pericarditis would change the entire thing. Valsalva decrease, Valsalva decrease the preload, no? Because Valsalva means that in Valsalva there are various steps, doc. Various phases of Valsalva maneuver. But when you're trying to forcible expiration, because inspiration is where you would be having more blood coming in the heart. Somebody put up that query. Inspiration is negative pressure, no? So negative pressure implies that you would be like the blood will be sucked into the heart. So more blood means more turbulence. So murmurs on the right side become louder with inspiration. The murmurs on the right side become louder with inspiration. So inspiration is only to differentiate between left and right side. That's not gonna impact the overall murmur per se. Like I have to differentiate MR versus TR, then inspiration is okay. And Valsalva, you're doing the opposite of what you are doing in an inspiration. So therefore, the result would be totally opposite. I hope that clears the doc. I'll say that again. Inspiration, you're breathing in. Valsalva, you're doing a forcible expiration. So the hemodynamics will operate totally opposite. Okay, cool. I think the answer for this one is Valsalva maneuver. And the reason, as I've explained, is Valsalva will make the murmur remaining steps, it's always going to be less. But Valsalva will behave, Valsalva, all murmurs become less, HOCM is louder. That's the basic concept that he wants to say. हैंड ग्रिप डॉक्टर उल्टा होता है ना हैंड ग्रिप में पेरिफेरल रेजिस्टेंस बढ़ा दोगे ना व्हेन यू शेक हैंड्स विद द गाय व्हेन यू डू अ हैंड ग्रिप द पेरिफेरल रेजिस्टेंस will increase and that will decrease the gradient between the outside and the inside of the graph. So if you are going to be having a decrease in the gradient, then the murmur will become softer na. The question was increase. In hand grip उल्टा होता है आप I would suggest you to just listen to the murmur section and towards the end of, like, it's a short video guys, 50-55 minutes only, उसी में सब covered है. So if you go to the last part of the murmur section, this part has been explained, the hand grip part. Logic is hand grip peripheral resistance is more, the gradient between outside and inside is lesser. So it's a softer. But Valsalva, it will be opposite, as I've explained it. Okay, guys, we are sorted from this one. I think this I don't need to explain. I am not sure it was matched the following or which way. This is how I got it. And there are 4 ECGs for atrial fibrillation, atrial flutter, PSVT, and then ventricular tachycardia. So, I've sorted them out before you. So I'm not sure whether you can just let me know if this was matched the following or what kinds. That would be great. But I think there was a question on the common tachyarrhythmias. In session 2, atrial flutter, I think there was a question on treatment part. Please comment in the chat box for the treatment part if you can let me know. What were the options for the treatment? Okay, match the following. So it's okay. I think it's a straight one. Right. Okay. This was shift 1. Then he has talked about match the following. So yeah, doc, I think it's pretty understandable. I'll go with this one. Okay, fine. Hopefully, guys, RR should have a good strike rate. Then he's talked about a drug that will cause torsades de pointes with erythromycin. So if you listen to polymorphic ventricular tachycardia, then polymorphic ventricular tachycardia, this is the aspect. Erythromycin, cisaparide is banned because of this reason. Estamizole is an antihistaminic drug. Ketoconazole, if you do any combinations, so that was like... yeah, estamizole is the correct answer to this one. So that's torsades de pointes, polymorphic VT. This is the primary reason why these drugs have been banned, because they contribute to interactions with macrolides. Yeah, Krishna. It's actually a PYQ, but not maybe asked the same way. But anyway, like I did put up in the routine videos. The next one talked about a patient with excruciating chest pain with unequal radial pulses. Let me know if the language of the question is correct and whether it was a question on aortic dissection in the very first place, whether it was aortic dissection. And if it was like anterior, I mean, it was anterior, was it a posterior one, type A versus type B? Yeah, Cisapride was asked. I think medicine world, you were perfectly right. Cisapride has been asked, and this time they asked about estamizole aspect. Okay, guys. So waiting for your comments here. A hypertensive patient with aortic excruciating chest pain with unequal radial pulses that would make it aortic dissection. And then he's asking me about the management. So if it is anteriorly placed, then I'll say emergency surgical repair. Okay, Stanford B was given in the question only. Okay, doc. Thank you. I'll just add that. So if Stanford B is given, then we'll go for medical management. That would be BP control. Histo-based aortic tear question. Yeah, doctor. I do have the language of it, but I thought that maybe the pathologist would like to handle that. But I got it. Like the tear part, the collagen degeneration part would be there. Okay. Yes. Stanford B is doc because we would like to go for control of hypertension. No, in Stanford B, in type A aortic dissection, it's always a surgical repair, but in type B, it's mainly a medical management. Though if it's like a leaking type of I would say aortic dissection, that is when surgery would be required. Yeah, Dr. Meet, I'm coming to this question, very interesting one, that atrial flutter ECG that you have just discussed. So I'll just come to this towards the end. I do have this question, Meet Patel. Give me a second for that. Give me a couple of minutes for that. So I think this is fine. If Stanford B is given, we are sorted for BP control and monitoring in this case. For the next question, he said patient is having shortness of breath. We are having tachycardia, blood pressure value I'm not aware of, so let me know. But I could pick up diastolic collapse and let me know, was it diastolic collapse of atria, diastolic collapse of ventricles? Though, I mean, the way the question is framed, diastolic collapse of ventricles tells me that he's talking about cardiac tamponade. And because of this cardiac tamponade part, I'll answer this as pericardiocentesis, but just waiting for inputs for the blood pressure value. I mean, was it okay? Atria. Okay. Okay. X-ray was given in this one. Cool, man. Chest X-ray was given. Okay. So chest X-ray showed a money bag appearance with a increased cardiothoracic ratio. That's okay. There was a money bag that is present. I think this question then becomes very similar to the one that I discussed in a recent FMG kind of a question. Even that in FMG exam, they put up a question on cardiac tamponade. Though, I mean, the whatever they asked was slightly different. Any blood pressure values? Okay, 130 by 80. Okay. So it cannot be collapse of the ventricles this time, right? Is it ventricles collapse? Cardiac, I get it, doc. I get it. Cardiac CT ratios increase, money bag is there. So I think we are talking about a large pericardial effusion in this case. That's understandable. Please let me know, is it collapse of ventricles? Because BP of 130 by 80 with collapse of ventricles is a little unlikely. But I could see a comment saying atrial collapse. Okay, Krishna. So this would be atrial collapse. So we are talking about a low pressure cardiac tamponade. I mean, the situation that he's trying to talk about is a low pressure cardiac tamponade, and that can deteriorate into a cardiac tamponade. So I would like to manage this patient. Yeah, atrial collapse. Okay. That's okay, doc. I mean, the point is, if it's an atrial collapse only, that means there's almost a 30% decrease in the blood pressure. Because when you listen to cardiac tamponade, it would be two things. One is plain cardiac tamponade. Second is low pressure cardiac tamponade. It can deteriorate into cardiac tamponade after all. So, I mean, in cardiac tamponade, BP will be unrecordable. At the moment, this is perfectly okay. I mean, if blood pressure is 130 by 80, I'm okay with this at this juncture in a sense that he can deteriorate subsequently. So what is best? If you look at the other options, intra-aortic balloon pump would be for cardiogenic shock, ventricular assist device would be for medically refractory congestive heart failure. So, and there would be no role of diuretics because initially I thought that he's talking about only congestive heart failure. But then the way it is, the word diastolic collapse lets me know that we are dealing with a case where there would be a development of low pressure cardiac tamponade deteriorating into cardiac tamponade. Why not a conservative management for this one, doc? He will deteriorate, right? So if I have a patient with, let me say, a lung cancer, And if I do a conservative management today, I mean, it's like I'm postponing things for tomorrow, but then he is bound to get affected. It's not going to change. I mean, the lung cancer, the malignant pericardial effusion part is not gonna, it's gonna be merciless. I can put it that way, that the malignant pericardial effusion keeps on deteriorating the patient, the amount of fluid keeps on increasing, the ventricular collapse would be occurring subsequently. So that makes a pretty a decent sense to not try and brush things under the carpet. That's how I can put it best. And therefore, pericardiocentesis would be a good one to manage this patient. पेरिकार्डिटिस तो नहीं हो रहा सर, अभी तो पेरिकार्डिटिस से ऊपर उठ गया ना, because the chap is having a ventricular, I mean, if there was nothing mentioned with respect to any echocardiography finding, then it's a wild guess with respect to what could be the possibility. But the way it is, I mean, I am having a patient who's stable at this moment, but then he's having a low pressure cardiac tamponade, so he can deteriorate into cardiac tamponade is the option that I would like to say. Avinash, let me know the options there. That would be so great. Yeah, Meet, I got your point. Medical management is an okay statement. I'll say that again. I mean, I can do a medical management, but it is like brushing things under the carpet. Avinash, if you can help me with the options, that would be cool. Okay, so this was Stanford B. Then we are done with this diastolic collapse. Yes, waiting for inputs there. Okay. Moving to the next one, I still giving another few seconds, 5-10 seconds for somebody who would like to correct me the options there. Yeah, first step. Okay. Okay. What is best step? What is first step? Okay. Doc, even if I go for the first step, no, I would not like to give a diuretic in this particular case. It will not change anything. No? It will not change anything. I mean, cardiac tamponade, congestive heart failure will not work in this case. I'm not saying pericarditis, man. The X-ray finding, even without an X-ray finding, no, if it is given, it is okay. I am not even relying on the X-ray finding for workup of this patient. I am relying more on the echocardiographic finding in this case. Yeah, doctor. Even if it is like initial step, why to? No, diuretics are used for congestive heart failure, man. If there is a congestive heart failure, I'll be using it. No, I'll say that again. I mean, why do we have a cardiac tamponade kind of a situation arising? It could be a lung cancer metastasizing to the heart. So even if I give a diuretic in this patient, it's not going to change the course. The fluid will keep on accumulating even then. Okay. Yeah, I agree. It is a pericardial effusion. Just let me know once again, collapse word given in a question or not. I would agree to, I mean, the conservative part, if you're like insisting it's conservative, I take your word for it, buddy. The only thing is, I just want to know if collapse is there or not. That's the only point. They're distractions, they that's the standard bread and butter for you. They'll give you questions in which like there would be 2 images, there would be 3 images. They're distractions. Yeah, I mean, most of the guys have voted for an atrial collapse, so I'll stick with that. I mean, if this cardiac chamber collapse is not given, guys, then it's a totally different ball game. But if we are talking about cardiac compromise, then I think we should stick with our answer there. Okay, great. Okay, moving to the next step. He said, which of the following is the next best step in management of a pulseless patient with the following rhythm? And this was a broad QRS tachycardia. Yeah, Dr. Sai, it is collapse. That's why I said, I mean, I'm worried about the hemodynamics, and that is why I was being aggressive for this patient. The question talks about broad QRS tachycardia. That would be monomorphic VT. And for any okay, this is a pulseless VT. So we will have to defibrillate anyway. And then, I mean, trying to check pulse is a waste of time. We would like to continue chest compressions in this patient. So defibrillate, okay, CPCR, okay. So defibrillate, continue chest compression. Was there a third point also? Check pulse subsequently? Because the way the options are, this would be defibrillation and along with that, continue chest compressions. Pulse will take some time to come. No? Like if I give a DC shock, it will not that the pulse will come immediately. It's going to take for a while to pulse to come back. So we have to continue chest compressions in this case. Okay, so no discrepancies in this one. Looks pretty decent. We don't give synchronized DC. Chest compression, check pulse. Yeah, doc, that's what I'm trying to say. That if there is like one option is chest compression, I'll just save that. That's a good option there. So I think the point is for PVT, no, it is like there is no point of checking pulse because there would not be any, no. I mean, the basic point that every time I describe these rhythms is that there is no point of checking pulse if there is like a pulseless VT described in the question. So it is defibrillation and then continue chest compression. The very first line, guys. I mean, every time you are going in for a DC shock, the defibrillation part and synchronized DC is anyway for PSVT and every time there's a R wave present. Okay, fine, guys. Then another question on irregular pulse. Please help me with the language. Was it a hypertension patient or a pulmonary artery hypertension patient? Because the question said loud P2. Because when I read this loud P2, I was like, it is asking about a large A wave. Okay, yeah. Okay, Krishna. Hypertension patient. Yeah, I get your point, man. I mean, I just wanted to, that's just for my clarity. I just want to know hypertension patient with a loud P2, or is it a pulmonary artery hypertension patient with a loud P2? No, no, no. It's not checking pulse, doctor. We don't check pulse. It is give shock and continue CPR. That's the algorithm that is always told. Okay, PAH, it's pulmonary artery, but it's a PAH, right, right, right. So that is what I was, because I was wondering like systemic hypertension having a loud P2, so that I was like, that's too far-fetched an issue. It's like pulmonary artery hypertension with a loud P2, and then pulmonary artery hypertension will cause structural damage to right atria, and that will cause the development of a atrial fibrillation. So this is gonna be like absent AVIP. Okay, okay. Even if that pulmonary, I mean, even if a okay, there is no PAH term, no PAH. Okay, fine, man. I'll still go by that. I mean, my point was only why is it happening after a while the story. So it's okay. I mean, even hypertension patients later on. No, it doesn't matter. It doesn't matter. The main keyword is loud P2. Loud P2 would mean that there is a pulmonary artery hypertension, and due to pulmonary artery hypertension, there should be a presence of a large A wave in a patient. So I was thinking canon A wave cannot be an answer because canon A wave is always gonna be AV dissociation. Canon A wave is always AV dissociation. That would be like ventricular tachycardia, junctional tachycardia, third degree heart block. Those are the situations where we'll be getting it. So we do not have any discrepancy. It really doesn't matter as long as it's a irregular pulse that tells me atrial fibrillation. So in atrial fibrillation, the core aspect would be an absent AV. So that loud P2 thing is, I think, again, a distraction in the question. Krishna, that would be, I mean, if you want to use the English version of it, I mean, please go ahead and do it. And that would be extremely useful for you in case you just want to brush through the main aspects. Okay, guys. No, no, doc. Anishu, you don't need to even check for anything else. I mean, as long as it is irregular pulse, you are cool to go ahead with absent A wave. I was just trying to work out all the aspects there. Okay, cool. Let's move on to the next one. This, I think, mentioned CKD. And with CKD, I think it has to be electrolyte imbalance, that is hyperkalemia. Just let me know if CKD word was given or like that is what is only introduced subsequently. The vertical height of the T wave, once it starts going bigger, like in couple of leads, it's going up to more than 10 millimeter. That would make it a tall tented T wave. So yeah, there is a English video, doctor, coming up. That would be in the rapid revision section. So if you go through it, there's the English part that I've also taken care of. In this case, considering that it is CKD, tachycardia, and then a tall tented T wave, that would make it hyperkalemia. Yeah. Okay. So if CKD is not given, I can still pick up those pointed T waves. If it is given, even then that doesn't change much as far as the question is concerned. I mean, I'll go by the ECG findings then if CKD word is not given in the question. Okay, Dr. Ashi, not today. Today, my focus would be mainly to just get these things sorted out so that we can have the correct options there. CKD and diabetes mellitus. Okay. That makes it even more easier. No, the moment you read CKD, the first electrolyte imbalance that would be present would be like, I think that this would be a bonus question then. I mean, you read CKD, you know it's a hyperkalemic metabolic acidosis. Great. Hypo versus hypercalcemia. Sure, doctor. Here you always need to check the QT part. QT always has an inverse relation present. Every time they give you an ECG, if you are gonna be having, it looks like everything is perfect. Just then measure the QT. It's the last step that I've always mentioned there. I mean, hyper and hypocalcemia, either they're gonna give you situations post-thyroid surgery or a lung cancer patient with hypercalcemic crisis. And if they're not given any history, then ECG would look very decent, very straightforward, normal sinus rhythm, but it's the QT interval that you'll have to check. So that's the last thing that should be kept in your mind. Okay. यार अब मेरे को तो नहीं पता चलेगा ना कि कहाँ से आया क्वेश्चन. मतलब if somebody will tell me तो I'll not ask him ना कि बता यार ये फर्स्ट का है कि सेकंड का. Okay. Dr. Swati, in my opinion, that would be prolonged. Normally 0.12 to 0.2. So we'll say first degree heart block in a patient. Yeah, normalization is gonna be extreme. So 60-year-old lady presents with shortness of breath and angina pectoris episodes, and the workup shows aortic stenosis. What is the reason behind these chest pain episodes? In aortic stenosis, we have a concentric hypertrophy of the heart, and in aortic regurgitation, we have a eccentric hypertrophy of the heart. That is the basic fundamental difference between the two. Concentric hypertrophy में muscles मोटा हो जाता है and it decreases the cavity size. And in aortic regurgitation, it is a eccentric hypertrophy where the cavity size will increase. The basic problem is concentric hypertrophy will increase the oxygen consumption of the heart, and that will explain the episodes of chest pain. Do let me know if I need to modify the options in this case. Why normal? Doc, normal if we're taking upper limit as 0.2, then 0.21 should be taken as an abnormal then. The correct answer for the current one that I have mentioned here before you would be an increase in oxygen consumption. The remaining options are like I mean, if it was aortic regurgitation, I would have thought in terms of volume overloading of the heart, because in aortic regurgitation, the blood will leak back and that will cause a Frank-Starling law to operate, and that Frank-Starling law would subsequently contribute to a increase in the pulse pressure. Okay, Dr. Sanjay, I'm just waiting for options there. Pericarditis, is there breathlessness? Or Mohammed Salman, which question are we talking about? I could not pick it up. Let me know. And Dr. Sanjay, I'm just waiting for if you want to modify this one. Okay, fine. The next one talks about a patient with joint swelling, then with pansystolic murmur, negative rheumatoid factor, and elevated ESR. Considering that there is a joint swelling, and then there is going to be a pansystolic murmur. So I'm talking about arthritis and a carditis component there. Negative RF factor helps me give credibility to the diagnosis. Then would be pain in coarctation of aorta or aortic stenosis. Yeah, increase in oxygen consumption. Yes. Yes. Okay, what is more? That I was looking for because that is what I've written. AS and AR, I think, was there in the question. In both AS and AR, there is going to be presence of angina episodes, but the main reason would be that in AS, it is increased oxygen consumption, and in this is aortic regurgitation, guys. This is what I'm trying to say. The difference is एक में concentric है एक में eccentric है, तो दोनों में difference हो जाएगा ना कि volume overloading हो जाएगी जो volume overloading हो जाएगी when it comes to aortic regurgitation in a patient. Okay, work of volume of work increases or pressure work. Fine, guys. Got it, Subha. Got it. A preload would not be the answer in this one, doctor. It is always an afterload that will be taking into consideration. Aortic stenosis is all about an afterload that would be there. Krishna, I got your point, preload part, but then preload would not work up in this case. AS versus AR is always going to be an afterload, and it is preload with respect to if we are talking about let me say a case of aortic regurgitation. Okay, so this helps us in working out the answer to this question, and then would be joint swelling and a pansystolic murmur. This would be for acute rheumatic fever. Hypokalemia for Dr. CKD would be less likely now. Only if you give too much of diuretics that we'll think in terms of hypokalemia in a patient. Plus, there should be ST segment depression. Okay. This would be 18-year-old patient. That's great, Spreto. Yeah, too much of like it's difficult to recall only images, or it's difficult to remember the theory part, but then it's a part and parcel of our life. That's what happens, no? Information overloading happens, and when we are working in a hospital setting also, so it's okay. Mohammed Salman, I think I've answered that question as the first one. That why descent question with diastolic sound is not mitral stenosis, it is constrictive pericarditis. I'll say the reason for that again. Y descent is talking about a rapid filling, right? Steep Y descent or rapid Y descent was there. And that diastolic sound was not a murmur, it was pericardial shudder. That's the first question that I've discussed. So if you go back in the video, in the first question I've taken care of, that would be constrictive pericarditis and not mitral stenosis. I'll say that once again. I'll just show that slide to you just in case you raise that query. This is the language, loud diastolic sound. It was not a loud diastolic murmur. I mean, checked with multiple people. So that would be a pericardial shudder. Okay, so this would be acute rheumatic fever. Yes, Nidhi, I agree to you, considering that they put you guys through so much of, I would say, turbulence. It tends to upset the mental rhythm, and then one is not able to cope up. I agree to that. I mean, this was very unfortunate, and that's how system operates in India. It's everything is a mess only. Okay. A patient presents with wheezing that improves with as needed use of albuterol. He's talking about bronchial asthma, where spirometry is showing FEV1 between 70 to 83. So it's an asthmatic where the range is going to be more than 12%. But because patient is having recurrence of symptoms there, so you can see that we are giving only salbutamol, whereas in algorithm, it is ideally we should be adding steroids in these patients. I mean, because there is a poor control present, it is as and needed, but because there are symptoms in a patient, so we should add steroids. Why I'm not talking about prednisolone is because I want to reduce the side effects that can be seen with oral steroids. So it's inhaled steroids that would be recommended. Why not replace with salmeterol? Then I can say that salmeterol, even if I give it, is not treating the inflammation of the airway. It is only symptomatic control that I'll be able to achieve. So every time we read about this, no, I mean, in every step, they say that as soon as possible, try to introduce steroids. So even if we don't remember the table, still considering that person is not responding to only a bronchodilator, instead of trying to give the person a longer duration bronchodilator, what we should do is start adding steroids so that the inflammation in the airways can become relatively lesser. ECG in case of CKD had a ST depression in lead 2 and 3. No, doctor, no, not at all. Because if I'm talking about chronic kidney disease in a patient, then first electrolyte imbalance that I have to consider would be hyperkalemia. Hypokalemia is seen in those cases of acute kidney injury who are in a recovery phase. Because when you start treating them with diuretics, that's where hypokalemia can occur. So I think my thought process would be that I'll go by common things first rather than thinking of less common things. I mean, that would be my solution to that, or my inputs for the same. Okay. Okay. One option was add steroids. Another was moderate dose steroids in a patient. Okay. So doc, we'll not go by moderate, we'll ask low dose steroids. So I think first option would be oral. No, no, doc, we don't give oral steroids. No, 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 that is always, that is why, no, oral steroids तो last resort है ना. आप देखो, oral steroids तो avoid करते हैं. Oral steroids are not used in poorly controlled asthma, not at all, sir. That is why we have newer approaches now. That is why they talk about omalizumab or mepolizumab in a patient. I mean, if you listen to the asthma update, that is what I tried to explain, that in government hospital, the way things are, that's totally different, that we give steroids left, right, left, right. But otherwise, I think the standard thing would be that we should go by the algorithm, that is inhaled corticosteroids, and it should be lowest possible dose of inhaled corticosteroids to be given. Okay, Priya, that is great to know. As long as things work out, that would be great. Moving to the next one, this was a patient who was having severe leg pain, fever, chills, retroorbital pain, and conjunctival suffusion. I just want to confirm whether these two words were there, severe leg pain and conjunctival suffusion, because I initially thought the question is on dengue fever. But then these two words were very vocal as far as leg pain, or I think it was leg pain or back pain, I'm not sure. So let me know. And the conjunctival suffusion term was given. No, we are not stuck to the old protocol, doc. Absolutely not. Harris, see, whatever textbook will give her, we will have to follow that, no, doc. If they make a question paper, then I mean, going by Gina, and that is not published in the textbook, I would not like you to go ahead with it. It is textbook data that I have given, and I think that is the one that should be followed. Okay. Okay, cough pain is there. Conjunctival suffusion would make it leptospirosis. I mean, though a high error of diagnosis can be made, high incidence of errors of diagnosis can be made between the two. But then these two words in a question are like, I think, in your face, which give you diagnosis as leptospirosis. Okay, Dr. Venkateshan, I think the video of yours is a little at the back, and that's why the comment came up late. Moving to the next one, in this question, please do help me with the options. I think all arrows were going down, down, down. So we are talking about metabolic acidosis. And then with metabolic acidosis, if we try and calculate the anion gap in this case, my mathematics is bad, but I'll just try. This would be chloride, and then bicarbonate would be 6. So fairly unelevated, so high anion gap, metabolic acidosis. Okay. The answer for this would be HAGMA, that is high anion gap metabolic acidosis. SK, do let me know if you want to modify the options. If leptospirosis is not there, then what other diseases, I mean, what disease was given in place of it? Because honestly, when I read it, retroorbital pain, I first thought it is dengue only. But then when I read through the remaining part of the question, this leg pain and that conjunctival suffusion, that's what I was wary about answering as dengue. Okay, high in gap metabolic acidosis with partially compensated respiratory acidosis. Okay, okay. Thank you, low spreto. I'll just add that for the question. Okay, this would be partially compensated. Okay, yes, respiratory alkalosis. I'll just add a short word for that, just for my reference for my notes subsequently. Okay, Shiv, that's interesting because see, I wanted to know that bone pain. I think bone pain will be a feature, break bone fever. No, I think you are trying to go into dengue. But then even in dengue, the word is myalgia only. It is not that it causes damage to the bone. It is like break bone fever is just a colloquial term that is used to describe dengue. We don't have bone pain in dengue. Okay, hypokalemia. Okay, fine, fine. I got it. I think I picked up that word there. Let me just check where that farmer question went. Okay, hypokalemia. Okay. Okay, bone pain also given. Fine. Dr. Hitesh, I got your message, but then I could not pick it up. So please just mail me, just copy paste this in the email also. That is marvamedicine@gmail. And I'll be trying to sort it out before you because otherwise it doesn't make me help at this moment. Yeah, diagnosis changes with every word, doc. Yes, absolutely. GINA guidelines that are given in Harrison, doctor, they are the older ones, no? They are the older ones that are given in the older edition, in the 21st edition of Harrison. But I think paper is created from the textbook and paper is not created on the basis of guidelines. So that would be my take. I mean, I agree that there would be a lot of people who would agree, would be happy to disagree on that. Uh, I mean, the examiners, after all, have some answerability. So textbook reference should be given. Okay, ji, fine. This was, I think, blackening of the palmar creases. Let me know if blackening of palmar creases was in the options. Blackening of palmar creases or sole creases is a characteristic feature that we see with Addison disease. I think Addison disease word was not given. Remaining features are telling me that aldosterone is less, hypotension, hyponatremia, and then ACTH elevation. Yep, that would be leptospira and primary adrenal insufficiency. Okay, knuckles. Fine, fine. Should a palmar creases, that does not change the answer to a question, guys, because everything else remains fine. Hyperpigmentation can be on the hands, it can be palmar creases, it can be on the knuckles of the patient, even the lips part, the gingiva part. So, I mean, it's not only restricted only to the palmar and the slower creases. Okay, fine. This would be primary ACTH deficiency. That would be Addison disease. Doctor, primary Addison deficiency is okay. Okay, let me know if Addison disease is there, guys. If let me know if Addison disease in the options of this question. Okay, I think there was Addison disease also. I think there is a statement there. That would be perioral blackening was also given. Fine, I'll put it there. Yes, guys, please help me modify. This would be was Addison disease in the options. That will make it very easy for you. Okay, guys, then the answer for this question is not secondary Addison. Then it is like Addison disease as an answer. I'll go by Addison, guys. Addison disease as an answer because hypotension, hyponatremia, aldosterone is less and ACTH is elevated. Perfect. Answer would be D, guys. Answer would be D for this one. Okay, fine. Fine. Knuckle, doctor, it's not knuckle. It is hyperpigmentation of these IP, interphalangeal. It's not only the knuckle, but it is the interphalangeal joints also that would be present in the patient. Plus, if it is B12 deficiency, like if in the one, if there is, okay, B12 deficiency was given. Okay, fine, got it. In B12 deficiency in a patient, we would not be having hypotension and hyponatremia. BP was 80/60. Okay, that is my point, guys. That is my point. I mean, you would not be having a hypotension with hyponatremia described in a question for vitamin B12 deficiency. Okay. Okay, knuckle hyperpigmentation and hemoglobin was same question, guys. Hypotension is there, guys. Uh, yes, I think Nitesh is right. There are two separate questions, and I think we are now beginning to mix up the two, and that is the reason why it is happening. My question was be like this. I think we are mixing up the two. If we're talking about hypotension and hyponatremia, I agree to you guys. If you are talking about only low hemoglobin, let me just rephrase. If you're talking about low hemoglobin and hyperpigmentation over the knuckles of a patient, blackening, I agree it would be vitamin B12 deficiency. I have no issues with that. But talking about a question in which there is going to be hypotension, there is going to be a hyponatremia present, then I first have to think in terms of Addison disease. So I think maybe we are mixing up with the two situations in this case, because if it is if hypotension is there, then I mean, you have to justify it. No, you cannot say that it would be a vitamin B12 deficiency. Yes, in primary ACTH deficiency, there would be no hyperpigmentation. I agree to that, doc. That would not be there. Yes. Considering hypotension present, I'll stick to my answer, guys. That would be Addison disease. Otherwise, if you say, sir, no hypotension in the question, no hyponatremia described in a question says low hemoglobin, hyperpigmentation of knuckles, cool, man. That's B12 deficiency. Okay. And this was a physician evaluating a patient for an occupational disease and copper of porphyrin levels are elevated. That would be ALA. And yeah, I agree, confused medico. There would be a separate one. So I'll just put a +1 for this, for the hyperpigmentation over the knuckles of the patient. Cool. No, doc. I was the word was I was searching for Addison disease in the question actually. But Addison disease, once I get in the option, then it makes it easier for you. Okay, fine. Let's this would be lead poisoning for copper porphyrin. And then I think this the pathologist would have discussed the myocardial disarray part. That would be hypertrophic cardiomyopathy. The question was like basketball khel raha hai, and while playing basketball, the guy has collapsed, and that is when he would be having a sudden death. And the biopsy finding was given subsequently. So we'll go by hypertrophic cardiomyopathy in this question. Okay, Shiv says Ninja Star. Let me know, guys. Was it Ninja Star? I mean, a guy playing basketball with dilated cardiomyopathy is very, very unlikely, no? Because dilated cardiomyopathy, doctor will always be having a low ejection fraction. So for a guy to be able to play basketball with dilated cardiomyopathy, थोड़ा सा मुश्किल हो जाएगा ना. You see, hypertrophic cardiomyopathy, why they're able to play basketball is because ejection fraction is more, na? Ejection fraction in hypertrophic cardiomyopathy is elevated. So I think, yeah, I mean, what I am trying to say is that even if I am bad at pathology slides, मुझे नहीं समझ में आता है. So like I'll go by what is given in the question. I mean, a guy with dilated cardiomyopathy or any cardiomyopathy playing football, basketball, football is not possible, man. It has to be, I mean, school level football की मैं बात कर रहा हूँ, मैं प्रोफेशनल फुटबॉल की बात नहीं कर रहा हूँ. So a guy who's playing basketball, that is not possible, guys. So that would, I think we need to come up with a simpler interpretation or simpler answers for this one. Okay, this would be HCM. Okay, family history of elder brother also collapsing. That makes it more compatible with hypertrophic cardiomyopathy. Sudden cardiac death in elder brother. Okay, thanks, Mahinder. If it is same, तो ठीक है यार. Mhm. Session 2 was deeper, Anisu. I solved that question that with Valsava it would be increased. I think I'll put it like this. वो पैथो हम ज्यादा पढ़ते हैं ना, तो इस वजह से वो हमें लगता है कि ये वाला थोड़ा इजी है. बट देन फ्रॉम द मेडिसिन perspective, hypertrophic cardiomyopathy will behave opposite of traditional maneuvers in a murmur. That is why Valsava will make it louder. Okay, this would be a patient who's done binge drinking with altered sensorium, slurred speech, unconsciousness, and that's what I always explained. It's always going to be thiamine followed by dextrose or dextrose followed by thiamine. And we will first give thiamine to the patient because otherwise it will worsen the manifestations of beriberi that would be occurring in this patient. So we'll go with option number A here. Otherwise, if I give dextrose first, it will consume the residual thiamine and will worsen the beriberi features in this patient. Okay, so get it. Now I get it. But this one is having treatment part. This helter-skelter arrangement. Okay, okay. In my books, it is not written helter-skelter. It is written as myocardial disarray. That's the word that you can check up even in Harrison also. Okay. I think we put up I think me and Preeti ma'am had put up a video on the Ninja Star part. So if that has come, that's excellent. They picked up the image directly from Robbins person. Okay, a patient presents with perioral pigmentation, hypotension. So I think you were right in the previous question. It would be question going in favor of B12 deficiency. And this is the one which is having Addison disease as a presentation. Okay. Hydro and fludrocortisone both are given. Okay, guys. Okay, got it. So considering that fludrocortisone is present and I am going to take care of the aldosterone deficiency. So this is a presentation of Addison disease, and for Addison disease, we give hydrocortisone and fludrocortisone both. I mean, hydrocortisone will be having both mineralocorticoid and glucocorticoid activity, but because the BP is dramatically low, so I would like to upgrade the aldosterone values as well, which is why fludrocortisone would be used. Yes, doc. I think that is what we should go by. That is hydro and fludrocortisone there. First answer is always hydrocortisone because you need to take care of both things, the hypotension and the hypoglycemia component, which is not described but would be present in the case. Okay, got it. So that makes it three questions, right? For like pigmentation part that you're talking about. One is the question on B12 deficiency, the traditional one, then is Addison disease, and the third one is for the treatment of the therapeutics there. Okay, no doc, will not give ACTH in this question. Great, great. Let me know was clubbing as a word was given, and also please comment in the chat box. The X-ray was which of the two? I'm not sure about the session, but I think patient is presented with fatigue, fever, which is 102°F with foul smelling sputum and distal clubbing. And there is a air fluid level which is present. So in case it's a air fluid level present, okay, clubbing is there. Okay, clubbing is there. And air fluid level present. Yeah, doc, just let me know. First X-ray. Okay, fine. So I'm putting a cross over it. Pyemia also given. So that makes it easy, doc. That makes it easy for me. I mean, like I always say like this, that fastest clubbing is always a feature of lung abscess, because clubbing is something that you don't see routinely, or it's gonna be occurring over a long duration. So any MCQ where there's like fever given and there is a clubbing given and some involvement of the lung, then you have to think in terms of lung abscess in the question. Okay, yeah, that makes it okay, man. I mean, if I'm gonna talk about this air fluid level, which you can see here, that would make it relatively easier for you. So the diagnosis in this case would be lung abscess. Cool. Empyema, yeah, let me know if empyema was in the options also. Gautam mentioned regarding empyema also. Short history, okay, 4 to 5 days. That doesn't change much, as I said, no, doctor. Every time there's a lung involvement, fever, and then he talks about clubbing, it's usually the question going towards lung abscess also. Okay, KK, I'll take that as one option, empyema. Fine. But then for empyema, the point against would be distal clubbing. I mean, that is what I wanted to confirm right in the beginning. I mean, the moment you read the clubbing part, then empyema would be like out of the window. And first you have to think in terms of lung abscess. Okay, he might have had emphysema, but then the remaining things that I've said, no, they are going in favor of lung abscess. Pointers in this MCQ. Yeah, coming to that shift, give me a second. We're coming to that question on lights criteria. So couple of seconds and I'll be able to sort it out. Okay, pneumatocele. That was a good one. Good option there. Let's move to the next one. Yes, this is what you are talking about. A patient has a pleural fluid with LDH level of 0.4 and serum LDH and protein greater than, okay, I think it's LDH more than 0.4 times the serum LDH, protein greater than 0.5 times. So only one criteria is getting satisfied. It doesn't matter. Out of the three criteria that I told you, the lights criteria that we've discussed, it is any one that is more. It is not that all should be more. It is like 0.5, 0.6 and more by 2 by 3. But if you read the data, it is not that all three should be more. It should be any one that is positive. So considering that remaining aspects, no, all of these, heart failure, hepatic failure, renal failure, they all will contribute to a transudate. And tuberculosis would be contributing to an exudate. So that is why this would be a presentation of tuberculosis. 0.6 and 1.2. Patient was having dyspnea. Okay. Shiv, can you just clarify that 1.2, what is the value that you're talking? Anyway, that will make diagnosis even much more easier for me. If you say 0.6 and 1.2, I'm really, really happy. Then it is like super cool for me. Because I said 0.5 for protein and 0.6 for LDH values. So if you say 0.6 and 1.2, I am out of the out of the limbo where like only one criteria is satisfied. Okay, great, man. I'll explain like this. If it is 0.6 and 1.2, you are in safe zone. If you've answered tuberculosis, nothing changes the answer, even if it is the data that I've said 0.5 and 0.4, because it is at least one criteria that should be satisfied. And suppose you say that I don't want to get into mathematics. Without mathematics only, if I have to solve, I'll go by exclusion scales, right? I mean, heart failure, hepatic failure, renal failure, they're gonna be affecting like, aldosterone is more in heart failure, renal failure, aldosterone is more, hepatic failure, again, aldosterone is more. So that's gonna be like, volume overloading, and that is why transudative effusions can be there. But tuberculosis is always an exudate. Yeah, doc, that's what I'm trying to say. Which is, yeah, Varshini, you were right. I think there was a question of community acquired pneumonia. I've been looking for it. I mean, I wanted to know if they gave curve 65 score or not, because I think there was a question cap could not pick it up till now in the chat. This one, doc, Shiv, this I'll say like this. ये पता है ये FMG एग्जाम में ना ये ऐसा ही क्वेश्चन पूछा हुआ है उसमें मैंने बोला कि ये मैथमेटिक्स करने का जरूरत ही नहीं है, मैथमेटिक्स मत करो उसको ना, वो ये ट्रांसोडेड एक्सोडेड से सॉल्व करो आप, तो आई थिंक वो ज्यादा आसान रहता है. आई मीन दैट इज माय टेक ऑन इट. आइडियली तो देखो, मतलब द बेस्ट वे इज यू शुड गो बाय मैथमेटिक्स ओनली. बट ऑनेस्टली मतलब मेरा मैथमेटिक्स कमजोर है, तो मैं आई if I was at your place, then I would have, if I was like at your place, I would not have gone into the mathematics part. I would like try to solve it on the aspects that I've said. Yeah, there is no curve 65. I'm looking for still for that question on pneumonia. I mean, the language of that question. So it would be really nice. If you can just type it in the chat box or maybe drop me a mail at marwamedicine@gmail.com. Yes. Anishu, I have that question. It's just coming up very soon on the monitor. Anishu, really, there was a calculator on the screen. Wow. Okay, what is the expected auscultation finding in this patient? Was it auscultation finding or what is the expected finding? Because I could pick up there are fractured ribs in the X-ray. I mean, that is what people told me, flail chest. So if it is flail chest, it would be simple paradoxical breathing because this chest segment will be sucked inside and it's not going to expand with the chest. Like when we breathe in, our whole chest expands, right? And if it's going to be a flail chest, then some part of the lung segment would be rather pulled inside. Okay. Okay, what is the expected finding? So I'll remove that auscultation word. This would be paradoxical bleeding. Yeah, you're right. This would be B. Remaining are like solvable. No, small breathing, they'll not give an X-ray. Acoustic, they'll not give a breathing. Bronchial is an auscultatory finding. Okay, flail chest, so cool. Paradoxical breathing. This one I have, doc, a patient who's having acute epigastric pain with increase in lipase. So I'm thinking in terms of acute pancreatitis. And then the X-ray is totally white. I mean, it was so white that we are looking for black. Normally, X-ray is like black only. It's so white that we are hunting for black, and that is when we'll think in terms of ARDS in a patient. And let me know if I need to modify the options in this one. Okay, non-cardiogenic pulmonary edema. Yes, Roy, you are right in that. Yep. ARDS was given in the option or non-cardiogenic pulmonary edema. If you want to, I mean, though we answered, sorted out the answer in this case. Okay, fine. I think we are sorted for this one. 2 liters of fluid given. Okay, so 2 liters of IV fluid was given in this case. Fine, I get it. Even if fluid was given, that is given for resuscitation in these patients for management of distributive shock. So the 2 liters would not contribute to cardiogenic pulmonary edema. Age of the patient. Yeah, 2 liters in 24 hours is not a big deal. Miliary TB was an option in this one. Oh, that is interesting. So he wants us to really deviate. Yeah, patient got stable and 2 liters. I got it, doctor, I got it. This was 2 liter when I'm saying no, that would be maintenance IV fluid only. It is maintenance IV fluid. So that would not contribute to overloading in the patient. Okay, answer to this would be option number C. And then we look at a stroke question. Let me know the wordings here. There is a crossed manifestation, like on the left-hand side of the patient, arm and leg weakness is there. On the left-hand side, it is like weakness in the leg. That is what he's pointing at. What I want to know from you is, in this particular patient on the right-hand side, he's saying the following words: facial paralysis with lateral rectus gaze palsy and nystagmus. Was it gaze palsy or was it like lateral rectus weakness? Because that is the only difference between the two. Yeah, palsy word is there or lateral rectus weakness is there. The difference between the two is only the fact that if I say lateral rectus weakness, gaze palsy means both eyes are not getting affected. That means nucleus is getting affected. Okay, so yeah, I did talk about Fovell syndrome. The basic point I'm trying to say is if it is palsy and it is nystagmus, then it is Fovell syndrome. And in case it is weakness, then it would be called as Millard-Gubler. The difference is कि जो Millard-Gubler होता है उसमें it is the sixth nerve that gets involved, but not the nucleus. But in Fovell syndrome, it's mainly the nucleus that gets involved. Okay, Doc, you said I discussed that in my YouTube session. It would be nice if you can just send me that link. I just forgotten which my YouTube session did I talk about Fovell. Locked in syndrome. Okay. Okay. Fine, Doc. I think we are sorted for this one. Benedict's is ruled out because Benedict's would be midbrain with third nerve is involved. Locked-in syndrome would be a brainstem stroke in a patient, like I've given example of Michael Schumacher, the Formula One driver, he has locked-in syndrome, and that's much more number of cranial nerves that get involved. Yeah, yeah, right-sided facial palsy, right. Left face palsy, but doc, it's okay. Right-sided facial paralysis, and then there is a lateral rectus gaze palsy. See, we are not basing a diagnosis on the basis of facial paralysis. Seventh is anyway gonna get involved. It is just that the differentiating feature. As long as seven is there, I know it is. I have to select between foveal and Millard Gobler only. The differentiating factor is only on the basis of the words that I've written. Is it lateral rectus gaze palsy? Both eyes getting affected, or only one eye getting affected? That is what is the differentiating feature between the two. Okay, fine. Nystagmus is not on the options. I'll remove that. But if having a palsy, then that still gives me answer as foveal. Okay. Okay, last session on YouTube for NEET PG, similar question. Fine, doc. I'll just check it out. But if it has, if I discussed it, then I think it would be easier for you. Cool. The answer to this one is option number A. We move to the next one. Patient is having anemia, depigmented hair, and myelopathy. That myelopathy, I'm not very sure. Was it present? Was it not present? Not aware of. But it was a mineral deficiency, and he's talking about hair and anemia. Then I'll bet my money on copper in this case. Doctor, in Fowell syndrome, no, the remaining thing would be 7 and 6 only. It's same as Millard Gobler. The only difference is this is the snapshot in Harrison that you can see. The only he has given only one line for this. Ki Millard Gobler mein he says that it is only lateral rectus weakness. That's what I've highlighted. No, I mean he'll not pick up anything outside Harrison. So it has to be the one that is mentioned in this case. Yeah, I think there's no myelopathy. Let me know if alternative words were there. So, but I mean, because of hair and that, kinky hair thing, along with anemia, which is there, very much there in these patients. It's a microcytic anemia. It's copper deficiency that I'll think it of. In ARDS question, patient was alcoholic. Okay, doc, I'll add that. That gives more credibility to the diagnosis of acute pancreatitis. Okay, neutropenia was there. Okay. Yeah. So anemia, then it's gonna be like depigmented hair, and along with that, neutropenia also present. Anything else you wanna say? Okay, I'll just write in short, otherwise it takes too much of time. Polymorphonuclear cells were lesser. Yeah, doc, I got it, Dr. Pramoda. Like it doesn't have a myelopathy, but then based on the remaining things, we would X-ray in this one. X-ray for this question, doctor. I think we are mixing up the two. I mean, there must be a different question where X-ray findings would be given, right? That would be X-ray of the scurvy. Yeah. Okay, scurvy findings were given in the same question. Okay, got it. Mahinder Patel, thanks for that. I get the question there. Breathlessness, purulent sputum, community acquired pneumonia. Cool. I was looking for that. Great. Okay. Fine, got. I get it. Something like a scurvy X-ray was given in this case with Frankel line described. I get the point. Okay. Okay, doc. But then if we look at the remaining options, no, nothing fits the bill. Zinc is not gonna have this kind of a profile. I mean, the first two lines in the question would be thinking in terms of these only. Okay. Uh, Aspiration pneumonia in the previous case. Doc, if your ARDS is a known complication of acute pancreatitis, no? I mean, if you listen to the causes of acute respiratory distress syndrome, I have explained complications there, and one of the complications is ARDS in a patient. Fluoride will, okay, fluoride will be having intermembranous ossification, no? The radius between the radius and the ulna in the patient, and then the teeth part should be affected in the patient as well. Why not scurvy with iron deficiency anemia? Uh, Keeping two diagnoses would not be right. This is not scurvy. It is that in copper deficiency, we can be having findings in the bones also. Iron deficiency in a patient, doc, the depigmented hair part, the neutropenia part, if you listen to the copper deficiency part, hyperocupric manifestations, then you'll realize the impact of copper. Zinc will be acrodermatitis enterohepatica. Agree to that. So that doesn't fit the bill. Okay. Iron, doc, I've already explained. I'll say that again. I mean, iron deficiency anemia, depigmented hair, neutropenia doesn't fit the bill. Okay. Moving to the next one, I think this was, I don't know the shift, Wilson disease, neurological manifestations. Piece of cake in this case. We do not diagnose with serum albumin, serum ceruloplasmin, because ceruloplasmin can be low even in patients of cirrhosis, even in nephrotic syndrome in primary biliary cirrhosis. So this is not ceruloplasmin. It would be hepatic copper content. No, dog. The diagnosis, best diagnostic mortality for this. Ceruloplasmin, guys, I have explained so many times. Ceruloplasmin can be less in even kwashiorkor. Ceruloplasmin can be less even in kwashiorkor. It can be less in primary biliary cirrhosis. It can be less in even liver cirrhosis, because ceruloplasmin is a protein produced by the liver. So only in positive family history, I think it is only that hepatic copper content is the best diagnostic modality. We go in for a liver biopsy and estimation of hepatic copper content. Ideally, we should go for a genetic study to evaluate ATP7B loss of function mutation. But then this would be liver biopsy that would be used. Yes, it is line to line from the textbook, guys. This is line to line from the text. Okay, we sorted for this one. This would be C. In the next question, I think there was some ring enhancing lesions that were present, and we have to differentiate between whether they are tuberculomas or they are neurocysticercosis. And for differentiating between them, we'll have to go in for NMR spectroscopy. That would be the best way to identify that if it is tuberculoma, there would be a lipid peak present. If it is neurocysticercosis, there would be an amino acid peak present. So the differentiating feature would be a spectroscopy. MRS or a NMR spectroscopy would be the best one. Just let me know if there was like a ring enhancing lesion only, no, or was it a question on a brain abscess? Sir, I cannot have exact image. I cannot have an exact image. I can have only approximate images, but let me know if it was a brain abscess, because then I would like to change my answer to MRI serial scan also. Okay, doc, in case you got it correct, that would be so nice. Okay. Okay. Only one ring enhancing lesion, but there was a ring enhancing lesion. Now that is what I'm trying to say. It could be a single lesion, dog. I understand. As long as it is a ring enhancing lesion, then we'll go for MRS. My only worry was that it should not be like a big brain abscess with the air fluid level, because that is where we would like to go in for serial MRIs to see whether the brain abscess is increasing in size or not, and then we would like to go for maybe a percutaneous aspiration as well. Okay. Okay, great, Doc. If you got all correct in shift one, that is cool. I am really happy for you. But then there would be people in shift two who would be totally dissatisfied. So it's okay. Uh, Shiv, you need to drop me a mail and I'll respond to you for this one. Okay, moving to the next one. This was a patient of hypertension, or was it atrial flutter? And then the patient has gone into heart failure. Okay, this Moin is coming up with a different question then. Option. Okay, fine. Ring enhancing lesion on MRI brain would be toxoplasma, tuberculoma, brain abscess, and calcified cyst. Okay. Great, great. Okay, this was atrial flutter. So I'll just modify that. It doesn't change much the remaining things, but we are just gonna solve it here. Okay. Fine, fine. ECG given, atrial flutter, sawtooth waves. Let's evaluate. Start on Okay, doc, doesn't matter whether flutter or fibrillation, the bottom line is still the same. Basal crepitations present, so that means the person is going into acute heart failure. And if it is acute heart failure, I would not be comfortable giving beta blockers to the patient. C. If it is gonna be doctor, for toxoplasmosis, the lesions should be in the basal ganglia. Otherwise, you always have to first think in terms of only in the basal ganglia, and it's unlikely to be a single lesion then. Otherwise, we'll have to take in terms of a calcified cyst or like tuberculoma. Tuberculoma again will be big and eccentric, single large lesion, eccentric lesion. Toxoplasma, doc, it has to be immunocompromised. It has to be basal ganglia only. Okay, start beta blocker. Crepitations given, Meet Patel, let me know basal crepitations in the question. Bilateral basal crepitations in acute heart failure. That's okay, doc. 5 days history is present. That's perfectly fine. Start on anticoagulants. Okay. No, doc, that's not the case. Let me just work it out. Okay, Vincent, go. You have a good option there. Irregular pulse. Let's just solve it in this particular case. We need to go in for cardioversion in this particular case. We need to give anticoagulants because they can contribute to stroke in this person. For beta blocker, I think give esmolol instead of digoxin. Okay. Give esmolol initial management except in the patient. Okay, fine. Let me just explain this here, guys. If person is having, if it is a arrhythmia, listen to me now. If there's an arrhythmia and there are features of acute heart failure in a patient, we cannot give beta blockers. We cannot give beta blockers. They're contraindicated. In fact, I can say like earlier lesions, I think NEET PG preparation videos that I did, in that there was a question in which I had spoken about rollout digoxin for management of heart failure in atrial fibrillation or atrial flutter patient. We will use digoxin for rate control if it is atrial fibrillation with features of heart failure. The word heart failure may not be given, but if there are rails in a patient, then in a rail situation, we are not going to use beta blockers. That's the point that I'm trying to say. If it is bilateral basal crackles, it is a feature of congestive heart failure. If you're gonna put brakes on the heart, if you're gonna slow down the heart using a beta blocker, I think that longish option of beta blocker, I mean, I'm not having the full option, but the point is beta blocker with calcium channel blocker. Okay, if I'm gonna use it, I'm like literally squeezing the heart and preventing it from working. So no, doc. What we will do in this particular case is we will not be giving beta blockers in the question. That is the final gist. Absence. Dr. BK, we have already discussed that question. The answer would be absent P wave in a patient. Even it is loud P2, but it was atrial, it was irregular pulse. Considering that, we will say absent P wave, absent A wave. The main concept is, guys, in all patients of atrial fibrillation with acute heart failure, we don't give beta blockers. Cool. Yeah, IV digoxin for rate control. No, because it will treat the heart failure component. No, also it will treat the heart failure component also. Okay. This is widely debatable. PR interval measured at 0.21 seconds in a routine ECG of a patient, and I'll not call it a normal rhythm in a patient. I'll go by first degree heart block since the PR interval in the patient is prolonged. 0.12 to 1 is normal, no guys. 0.12 to 0.2 is normal. If it is elevated, we'll go by first degree heart block. Yep. The language was like that. Yeah, incidental finding, doctor. Incidental finding. That is what I've explained. First degree heart block is always an incidental finding that can be present. Second, also, but it will show a drop beat, no? Why not answer the second degree heart block is they second degree heart block will always have drops. If there is no mention of any drops, then we will not say, no. It has to be drop beats given in a question. Yeah, AV block, that is same as complete heart block, doctor. Then the number of the P waves and the number of R waves should not be matching. Can be normal. Okay, athlete given. So that is that's giving more credibility to the diagnosis as first degree heart block. No, high vagal tone. If I say athlete, And then I say a PR interval 0.1, that's 0.21, that's because of exercise. No, the exercise part will contribute to a high vagal tone and then will contribute to this. Okay, guys. हाँ, यू हैव टू गिव फिटनेस सर्टिफिकेट। इस बच्चे का कैरियर क्यों नाश करें? नहीं, कैरियर खराब नहीं होगा। दिस इज फिजियोलॉजिकल मैन, दिस इज फिजियोलॉजिकल। इट विल नॉट कॉज ruining of a career of a guy. If you will say first degree heart block, that doesn't mean that it will contribute to any issues, because one of the leading causes is high vagal tone. You always get this in marathon runners. Will not call it normal, doctor, because it is going beyond the normal limit. No, so we cannot say that it is like, we can say that this condition can be attributed to a physiological cause, but then you cannot call it normal. No. Doc, I have read 0.2. If some book says 0.22, so maybe if they are using that book, it's okay. But standard books I have read is 0.12 to 0.2 only. Yeah, Mona, I agree to it. I mean, some questions are very nasty and created in such a fashion that they will always contribute to errors of judgment. But that's how things are at this moment. Doc, if you read the textbook, no, first degree heart block, the first thing that they mentioned is a high vagal tone. Mona, sometimes, life will give us challenges. This is one such day, one such evening when suddenly you're listening to a discussion and suddenly one question is going right. Believe me, destiny always ensures that if you're getting something like this one wrong, there would be some that you would have got right, which other people would have got wrong. The law of balance is always there. So believe me, I mean, we all go through this despair. Everybody goes through this cycle. It's just that's a part of life that we all get used to and get adjusted to. And it would not be like this, that okay, I got this one wrong, somebody else would have got a different one wrong. So it's a great balancer nature. Okay. Okay, the ABG. Yeah. This one is again having all the values going down, down, down. That would be PCO2, and then yeah, pH is bicarb, but all three are going down, so that would be metabolic acidosis. Okay, Krishna, that's really great. So there would be metabolic acidosis, and then there is a high anion gap in this particular case as well, 136, 112. Yeah, that will help me in saying this is high anion gap. I think the way it was conducted was more of a harassment. You guys would have been more relaxed without the accessory things that happened. Great. Let's move on to the next one, which said in type 1 diabetes mellitus, there is a stage 3 beta cell destruction. I mean, this is atrocious to ask, but then stage 3, what he says is that there would be hyperglycemia and the patient will become symptomatic. I mean, I would have, if I go into a guesswork there, I would have answered this as a patient who's going into symptomatic stage. Late no, doctor, I don't have that question on late compensation. Please send me and I'll be glad in case you send it. Yes. No, no, doc, it would not be dysglycemic. It is hyperglycemic and symptomatic. No, just read this data, man. In stage 3, it is symptomatic patient and the person would be having hyperglycemia that would be present. Call duty, I'll be waiting for your answers. For stage 3, we will say the person would be having symptoms and would be having hyperglycemia. That would be hyperglycemic and symptomatic. Dysglycemic तो यार वो होता है ना, impaired glucose tolerance. Dysglycemia in English basically means impaired glucose tolerance in a patient. So if I'm talking about something where there's like person is having substantial amount of damage, then I'll say okay, he'll suffer from the disease. No, why will I say that he'll be having impaired glucose tolerance? And then there were two options with dysglycemia. That again is like, that maybe like one option is I select them, second is I don't select them. So if I'm doing into a guesswork in this question, I'll say okay, stage 3 होगा तो यार आगे damage हो गया होगा, तो it would be a hyperglycemic symptomatic patient. Dysglycemia, I'll show the slide again, is impaired glucose tolerance. The oral glucose tolerance test in the patient would be affected. That's IGT, pre-symptomatic. Okay, ji. So sorted for this one. Then this is another question, a nasty one. There are two questions on myasthenia gravis. In case you're talking about the other one on thymoma, I will come to that. So please wait for a couple of seconds. Let me just complete this one. Patient of myasthenia gravis on mycophenolate and 5-sostigmine with hypercalcemia. And then is giving me a couple of options in this case. Uh, okay, this one, doc, you have to send me a mail, doc. I'll send you the link for this, or I'll send you the picture from the book. Okay. डॉक आप मेल कर देना ना मुझे marva.medicine@gmail पे, तो मैं आपको लिंक भेज दूंगा या आपको स्नैपशॉट भेज दूंगा पूरा पेज के साथ में। ओके। Myasthenia gravis patient presenting with hypercalcemia. So if I'm thinking in terms of hypercalcemia, either I was thinking lung cancer, but then to have two diagnosis in a patient is like really, really difficult. No, doc, this would not be drug induced. I'll think in terms of either a parathyroid adenoma or maybe a lung cancer, which could be present. And first, I'll think in terms of possibility of okay adenocarcinoma of the lung. Okay. So, doctor, we don't have adenocarcinoma as a contributor now. It is squamous cell cancer. Remember, it is, I was saying a non-small cell cancer, but then squamous cell cancer is the cause. No, adenocarcinoma does not cause hypercalcemia. It is squamous cell cancer that causes PTHRP, that is parathyroid related peptide. That's the reason why adenocarcinoma and small cell cancer can be ruled out. So I'm left between only two there, drug-induced and a parathyroid adenoma. And I'll go by parathyroid adenoma in those circumstances only. Otherwise, it is squamous cell cancer that I would have thought there. Yes. Doc, we don't use ceruloplasmin for diagnosis primary parathyroid adenoma. Okay. Doc, we just have to rule out the options in this particular case. It is that it could be an isolated illness that is present in a patient. I mean, this is only a distraction that a person is having medication being taken, but then there is a hypercalcemia cause that he wants me to pick it up. I mean, that's the only explanation. Otherwise, I would have picked up squamous cell cancer as the first thought process. That's one of the leading causes of development of hypercalcemia, no? Hospitalized patients, squamous cell cancer. So if squamous cell is not there, then I'll think of another much more different possibility there. Okay. Primary parathyroid adenoma, doc. That's what I'm thinking, right? Okay. Moving to the next one, Ashwin, that's a good one. Renal tubular acidosis. Do let me know the options for this one. Okay. Most common cause of death in idiopathic pulmonary fibrosis. All lung diseases will contribute to damage to will cause pulmonary artery hypertension. And then pulmonary artery hypertension will ultimately cause respiratory failure in a patient. When the final word would be uh, two steps. First is pulmonary artery. COPD also has pulmonary artery hypertension, idiopathic pulmonary artery, idiopathic pulmonary fibrosis. Restrictive lung disease will also have pulmonary artery hypertension. But ultimately, in all of these patients, there would be a development of a respiratory failure in a patient. Yeah, doctor, pulmonary artery hypertension. I agree to that. Pulmonary artery hypertension is there. Doctor, the answer would be ultimately क्या हो रहा है ना ultimately तो it is all lung diseases will contribute to it's more like filling up that file for the cause of death in a patient. So it is not the illness in the middle, it is the final contributor because the lung will shrink in size, so it will contribute to hypoxia. Yeah, pulmonary artery hypertension given, doctor, that's what is I have written here, but I am not answering that is because pulmonary artery hypertension is seen in all lung diseases, no? Every lung disease will ultimately contribute to PAH. So uh, what pulmonary artery hypertension ultimately will be contributing is development of respiratory failure in a patient. I put it up, Grishma. I put it up there. Pulmonary artery hypertension in the options. That's option number D there. What I'm not saying is because ultimately it's going to contribute to respiratory failure. The point is like somebody put that rightly, eventual COD, the eventual cause of death. Pulmonary embolism as an option. Okay, doctor, I'll modify this one. Quality, you need to just drop me an email. I'll see if I can just type it there, if they allow that email thing to come in. If you can just drop me a quick email, no, because the chat goes up very fast, so it's not possible me to read it separately. I just dropped my email. Please just send it. I'll be able to read it better. Okay, large sweaty hands, macroglossia, frontal bossing. That would be query acromegaly. First of all, no, doctor, not Dr. Mahapatra, not related. There was a question on acromegaly. Yes, no, guys. Large sweaty hands, macroglossia, frontal bossing in a patient. Couple of days, you just need to take it easy and then get back to books once again. I mean, that is the best opportunity that you have at this moment because you have so much of knowledge, so you can get your resources and pump. I mean, you can channelize your energy much better, and you can start reading. I mean, it's not reading under pressure; it's just that reading for the joy of it. And I can assure you, if you read for the joy of it, things are different. When you read under pressure, things are different. So it's just learning new facts every day. That is what we are always going to be doing in our lives. Okay, guys. So we'll go in for age-matched IGF levels. Thank you, guys. This would be acromegaly and it would be age-matched levels. Find out. 75 gram glucose. Okay. Glucose tolerance test. Got it. Doc, if it is hypokalemic, Ashwin, you said hypokalemic acidosis. No, that is going to be going in favor of RTA. Okay, cannot be 4 because RTA4 will be having hyperkalemic. So it has to be 1 versus 2. And then there is a alkaline urine, right? Alkaline urine means bicarbonaturia, and bicarbonaturia would be going in favor of RTA2, no? Ashwin, you put up those good options, just taking a snapshot of that. But that's perfectly a good question that you put up. And good that the chat rate was slow, so I was able to pick it up. And I'll say this once again, right? Urine pH is 9, so there is an alkalosis. There is a urinary bicarbonate content that is high. I mean, if you listen to the first word of RTA2, bicarbonaturia, so it's an alkaline urine, right? And second, hypokalemic acidosis will be seen in both RTA1 and RTA2. How do you differentiate is on the basis of the pH? I'll repeat my fact once again. RTA4 has hyperkalemic acidosis out of the window. You're left with an hypokalemic acidosis. Either it's going to be type 1 and type 2 because the urine pH is going to 9. That means alkaline. Alkaline would mean that there is going to be bicarbonatenuria present. And that is where I'll say this would be RTA2. Yeah, that would make it easy. And then I think there's a question of star sign. This star is little bad, the image that I'm having, but still it tells me that there is a subarachnoid hemorrhage present in this particular case. Yes, Navneet. If there is bicarbonaturia, it makes it absolutely no problem for you to solve it. I'm saying even without the word bicarbonaturia, I mean, I was able to pick it up in the comment simply because urine pH was strikingly high, urine pH of 9. Okay. Dr. Laishram, you need to like send me the options also. No? So like I was able to pick up that chap, put up a question with that options and I was able to pick up the question and answer it in a jiffy. So just I would require a bit of your cooperation for like letting me know the options and I'll be able to respond to you. This would be subarachnoid hemorrhage with aneurysm. Considering that there is a CNS malformation that we can, or a vascular malformation that is given, and a star which does not look like a perfect star, but then it's okay. I mean, it's still filling up the basal cisterns, so the blood is gravitating down into the basal cisterns, which is why that some of the limbs of the star can be seen. Intraparenchymal is going to be like a diffuse hemorrhage in the parenchyma, like I've shown for hypertension. So this image, like when I verified, like there is no parenchymal bleed that was present. Okay. A patient is having recurrent lung infections and then the chest X-ray is given. He says, what is the most likely diagnosis in this case? Dextrocardia given in the question. So then cystic fibrosis would be unlikely. And I mean, cystic fibrosis ruled out, and so is Dijog syndrome. Considering dextrocardia, we'll answer that as Karteniger syndrome. Okay. Patient is having headache, confusion, and a brain tumor diagnosis is made. There is a kidney tumor in the family. Considering brain tumor and kidney tumor, I'm thinking in terms of von Hippel-Landau in the patient. Okay, chronic SDH. Okay. It was like only maybe a CT scan of chronic subdural hemorrhage that might have been given, or maybe it was like he's asking about craniotomy or a leave from any man. You are having breast cancer and you are having a sarcoma and you are having a leukemia slab. Sarcoma, leukemia, breast cancer, SLAB is the mnemonic for leave from any. It is P53 mutation. It is slab, SLAB, sarcoma. It could be leukemia. It could be breast cancer that would be present. ओके दिस वुड बी वीएचएल डॉग बिकॉज किडनी आ गया ना किडनी ट्यूमर आ गया तो वीएचएल के फेवर में जाएगा ओके यंग सिंड्रोम इन द ऑप्शंस ओके डॉग दिस इज अ गुड इनपुट फाइन let me know the options for this one von Willebrand disease. I don't want to jump into the answer at this moment. Von Willebrand is one of the common bleeding disorders that would be presenting after 10 years of age, mostly will be a girl child. And I mean, if I just mark the answer, it would not be justified. So giving you a couple of seconds to just verify the options in this case for VWD. Because he played in English with all the permutation combinations of type 2 and type 3 as well. Type 3, the statement is correct. Okay, prognostic factor in dengue, doctor, this would be like if you listen to the discussion I've explained कि डेंगू में ना हेमाटोक्रिट देखते हैं क्योंकि डेंगू में जो एंटीबॉडीज द एंटीबॉडीज इन डेंगू दे कॉज कैपिलराइटिस बिकॉज ऑफ कैपिलराइटिस दे वुड बी contributing to fluid loss. That is why in dengue you always have pleural effusion, you have ascites, you have circulatory failure, and hematocrit 20% rise over the baseline is one of the important prognostic factors which is telling you that patient is going into shock. Platelet count is not prognostic because if platelet count is 50,000 or if it is 75,000 or it is 20,000, you are still not giving platelets to the patient. So that does not decide the prognosis. But it is like dengue shock syndrome is a much more pronounced complication in dengue. DSS is the word to be precise, which is why hematocrit would be the answer. Okay, doc. In this one, I'll answer this as C because you don't have since childhood, right? I mean, this would be severe bleeding since childhood. I'd say it's after usually 10 years of age that the presentation would be there. Okay. Think this is the last slide that I have at this moment. I don't know if this was in gynae ops, but very interesting. So I just want to discuss this one also. Dr. Elliot Anderson, I would need a couple of options for that to work out the delay in kidney taking time to correct the acidosis. It would be ammonia genesis. I mean, that's the protocol. But then I just want to go through the options just to say that it's an ammonia genesis which is defective. Doc, I need more clarity for the options for von Willebrand disease. Otherwise, I'll go by the answer that I mentioned. Okay. Okay, when to stop magnesium sulfate in a patient? Okay. No, no, not visual disturbances. Magnesium sulfate के लिए तो. Okay. Yeah. Okay, less than 14 per minute. Okay. Or more than 18. Okay, doc. I'll change that to 18, 14. See, respiratory depression value less than 12 is what the textbook says. Main point is if it is, what I can explain is urine output of 60 ml in 4 hours. That means 15 ml per hour. I mean, that is outrageously low, right? If urine output is 15 ml per hour, that implies the fact that it's person is going into acute kidney injury in a patient. Okay. Doc, doesn't matter. 14, 18 doesn't matter. It's not respiratory depression. Now, suppose there was a value going to respiratory rate going to less than 12, less than 10, then you are to consider that, no? Knee jerk is present, doctor. I think knee jerk present, sir. Otherwise, I would have marked it as B only, sir. If it was knee jerk absent, then I would have marked as B only. My first response was that only, that it is knee jerk is absent, but I don't think so. Right. Yes. Yeah, less than 30 ml makes it even less. No, if in 4 hours it is 30 ml, it is 7.5 ml, man. That would be like giving us A as an answer for this one. Yes, exactly. If knee jerk is present, that then I mean, I would not like to answer that. It is knee jerk absent that is to be considered. So urine output in this case. Yeah, this one is for shift one. So guys, I have done the slides that I have. RTA1 also alpha 7. So urine, no, it would be inability to acidify the urine. That is okay. But then bicarbonature as a word would make the answer as RTA2, doctor. We will not go for magnesium level to be checked. I'll put that visual disturbances, magnesium level to be checked. We will have to, I mean, straight away handle the emergency part. That is, there is a decreased urinary output because BP would be lesser. Yes, yes, yes. Yeah, Dr. Havaldar, you're perfectly right. Urine output less than 30 ml per hour. Okay. Okay, 30 ml. But even then, that would be lesser. No, normal is gonna be like 60 ml per hour, no, 1 ml per kg per minute. So that would be still 50% of lesser. Yep. Dr. Pramod, I've answered that hematocrit would be because DSS is what I've explained, capillaritis and dengue shock syndrome in a patient. Yeah, 0.5 से कम हो गया. Very, if you can drop me a mail, I'll just work it out and post it in my group subsequently for that acidosis part that the question is going on for delayed correction by the kidney. So guys, that's it from my side at this moment. It was absolutely an honor to be rather discussing all these things with you, and you guys have done excellent. So keep the faith, as I say always, and you will persist. You will persist. Okay. Pulmonary, Dr. Havaldar, you need to let me know that in the email. Okay. Okay, guys, thank you so much and God bless you. So nice interacting with you once again. And really appreciate the fact that you spare time and came. I mean, I know that people would be saying कोई फायदा नहीं है and ये सब बेकार की बातें होती हैं. But then I think it's on personal basis. You know, trying to dissect what has happened in the past makes us more adaptable to what is going to happen in the future. That's my take on this. Some people say take it easy and to hell with everything that has happened. I mean, that's okay. I respect the feelings. I respect that thought process also. But then taking it on the chin and then follow it up and then say, okay, this is went right, this went wrong. It helps me as a person to learn what went wrong yesterday and how can I improvise further. That is my bits there. So thank you guys. Thank you guys. Okay. Doc, this is very unfortunate, the Kolkata incident. In fact, I always say as doctors, we must stay united. And I saw a lot of infighting going on among doctors themselves. Uh, that is what other people are taking advantage of because we always make fun of each other, we criticize each other. I always say that every opportunity, I'm going to say it again, we need to stop this backbiting against each other and we need to stay united because that's how we fight. Otherwise, we are singled out, right? They know that we are the weaklings. Who becomes a doctor? Class 10th or 12th student, who's the most humble guy in the class? You know, if I was in class 10th or 12th, somebody came and slapped me, I'll not be embarrassed in saying that. In class 10th and 12th, I was the most meek guy in my class. I was studying, right? I didn't know anything else. And if somebody slapped me, I did not have the guts to fight back. I'll be honest in that. So a guy who has put in his entire life studying, and tomorrow you are gonna trouble him or a lady doctor, I mean, it's outrageous, man. It's a stupidity that is happening, and especially with the events that have happened subsequently, the infighting part that has to go. I mean, so we need to do more. And yep, we were doing brainstorming regarding whatever we can, but then social media, we can just vent it out temporarily. It's more concrete steps on the ground that need to be taken. So thank you guys. Thank you so much. Bye bye.